Welcome to Chapter 9, our hematopoietic system lecture. So this week we're going to go over diseases of the blood system and some of the blood system function. And one of the best parts I know you're going to appreciate about this chapter is that it's very brief. So it's almost going to feel like a week off. So the hematopoietic system is going to be really, really important, obviously, because without blood, we don't have life. So we're going to look a little bit at the physiology of the blood, diseases of the red and white blood cells, as well as diseases of the platelets, which are responsible for the clotting of our blood system. The physiology of our blood, we know that our blood system is made up of red blood cells, which are responsible for carrying oxygen and nutrients to our tissues. And the appropriate terminology for a red blood cell is erythrocytes. Our blood also contains a component of platelets or thrombocytes. And the thrombocytes are the ones that are responsible for clotting our blood when we have a cut or some other bleeding issue. Both our erythrocytes and our thrombocytes are made in the red bone marrow. So in early embryology, as early fetuses, we really make our blood cells in our liver. Then as later in embryology, we convert that to producing our blood cells in our spleen. And eventually, as we are born and grow, the responsibility of blood cell production goes to our red bone marrow. Now, in children, we have a lot of red bone marrow throughout our bones, but as you become adults, we have our red bone marrow is really housed mostly in our lumbar spine, our superior femurs, our hip bones, and our flat bones like our sternum and our cranial bones. The other type of blood that, or blood cells that we have that are very important are our leukocytes or white blood cells. These are also produced in red bone marrow, but in addition, they are produced in lymphoid tissue. And so some of our lymphoid tissues are going to be tissues like the spleen or lymph nodes or areas like that. So these are coming from not just the red bone marrow, but it's coming from other areas as well. Now, the process of creating or producing red blood cells is called erythropoiesis. And so that's going to be an important term to remember as we go through this chapter. Now, erythrocytes, or our red blood cells, are known for containing hemoglobin. And hemoglobin is an iron-based protein that is the responsible part of the red blood cell for carrying oxygen. So a red blood cell without hemoglobin is not able to carry oxygen out into the tissues of the body. Now, if we look and we break down the leukocytes or the white blood cells, you'll find that there's 5 major types of white blood cells. And the white blood cells are really responsible for the immune system. So again, these are made in our lymphoid tissue and in our red bone marrow. So the first type that we're going to talk about is the neutrophils. And a neutrophil is usually the first white blood cell that's on the scene when there's some sort of antigen. So an abnormality or something unusual is introduced into the body, a bacteria, virus, something like that. The neutrophils are going to be the first to address that. So they would rush to the scene and begin the inflammatory process. It's important to note that neutrophil cells only last about 8 hours, and so the turnover rate on these is very, very high. In addition, the main cell type that you would find in purulent or pus-like material would be dead neutrophil cells. The next type of white blood cell we're going to talk about is an eosinophil. And eosinophils are most commonly recognized as being important in the role of allergic reactions. So that's the most common place we hear these talked about, but they do also have a component that participates in the in the attack of any sort of antigen as well. That brings us to basophils, and basophils are most known for their response in asthma. So basophils rush to the area of an inflammatory response. And when these are activated, they actually produce a lot of histamine. Now, histamine is the thing that makes your nose run. It causes some of those allergy responses that we're used to trying to address. And the other thing that they do is they cause tracheal contraction. And so that's why these basophils are noted as being a responsible party for some asthma attacks, because that basophil production of histamine causes contraction of the tracheal or the bronchial tree, which then makes it difficult for someone experiencing an asthma attack to expel their oxygen or their air. So they're able to take air in, but they have an inability to move air back out, and so breathing becomes very challenging, and their oxygen levels drop. And so it's really the basophils that we hear about being responsible for that. Lymphocytes, these are our white blood cells that are also going to be important in producing immunologic responses. And then finally, our monocytes are like the cleanup crew. So these are the white blood cells in our blood system that are going to be responsible for basically macrophaging or breaking down any dead blood components that are in the circulatory system. So all of these components are very important to our immune system, obviously, because without these, if we had an antigen, a virus, or a bacteria in our system, we would have nothing to attack it, and it would be allowed to therefore reproduce and, basically take over our body system. So we're going to talk really quickly about diseases of the red blood cells. And there's a couple different diseases that we're going to look at. One is anemia, one is polycythemia. And if we look at the A here would mean no, and then emia would be blood. So anemia is not no blood, or else we obviously wouldn't be alive, but it would be low levels of blood. And then poly would be too much. Cy is going to be our cells, and then emia in our blood. So polycythemia would be too many blood cells. So we go from not enough blood cells to too many blood cells. So with anemia, there's a number of different types of anemia, but basically it's the decreased amount of oxygen-carrying hemoglobin in the peripheral blood. So it doesn't necessarily mean that we don't have enough red blood cells. We could have enough red blood cells, but if those red blood cells don't contain hemoglobin, they're unable to fulfill their task of carrying oxygen. So it could either be a low number of cells, or it could be the inability for those cells that are present to carry oxygen. So some different types of anemia are iron deficiency anemia. Now, iron deficiency anemia is a problem because with iron deficiency, the body's not able to produce enough hemoglobin. So if we don't have the iron to produce hemoglobin, we don't have the hemoglobin to transfer oxygen within the body. So having iron deficiency anemia might mean we have enough red blood cells, but they're just not efficient at carrying oxygen because of the lack of hemoglobin. Now, hemolytic anemia means that we have the red blood cells, but we have lysis of these blood cells. So with hemolytic anemia, we're creating a lot of red blood cells, but rather than functioning for a certain period of time that would be normal for a red blood cell, they are dying and getting lysed and broken down more quickly than they should. So they have a shortened lifespan. Then there's a megaloblastic anemia, where this is due to a vitamin B12 deficiency. This also affects the ability of our red blood cells to transfer oxygen, and so it can affect the oxygenation of our system. Any type of these anemia is often going to result in a patient feeling tired, having long capillary refill times, and just an overall feeling of lethargy. Another type of anemia is aplastic, and this is A means not, and then plastic would be developing or producing. So aplastic anemia would mean we're having bone marrow failure and we're not actually producing the amount of cells that we need to produce. And then we have I'm going to not say this correctly, so bear with me, myelophthinsic anemia. Now, this is infiltration of the red bone marrow with non-hematopoietic cells. So non-hematopoietic cells would be cells that don't work toward production of red blood cells and white blood cells. So if our red blood cell producers are being replaced by cells that don't produce red blood cells, then obviously our production is going to go down and our patient would have anemia. So looking at specifically a hemolytic anemia a little bit more in depth, there's a few reasons that we can have hemolytic anemia. So this is sort of an umbrella term, and it just says that we have a shortened red blood cell lifespan, and so our body's going to have to work harder to produce either more red blood cells or it's going to go without. So most hemolytic anemias are anemias that are caused by some hereditary problem. The first type is spherocytosis. Now, one of the main components of a red blood cell is that it is shaped like a biconcave disc, kind of like this if we looked at it from the side. And one of the things that our spleen is responsible is looking for the shape of a red blood cell. And when red blood cells are not appropriately shaped, our spleen pulls those red blood cells out of commission and basically breaks them down and releases their hemoglobin. So when we have a patient that has spherocytosis, rather than having this normal biconcave red blood cell, we have a red blood cell that is more spherical in shape. When that spherical blood cell gets to the spleen is going to recognize its abnormal shape and can pull it from circulation. So if a patient is producing too many sphere-shaped blood cells, they would all be pulled, meaning that they would have a lower level of red blood cells, resulting in anemia. Now, sickle cell anemia is similar in that it is an abnormal shaped blood cell. So with sickle cell anemia, it can have varying blood cell shapes. What we commonly think about it is like half moon red blood cells. So they can look like this, but they can have other varying shapes as well. Now, the sickle cell anemia population typically affects African patients or people of African descent. And so these patients will have episodes of exasperation and kind of remission where it does better and then they can get really sick and it does better and they get really sick. And that's depending on how many of their cells they're producing that look like these sickles. Now, again, the spleen is going to recognize the abnormal shape of these cells and they're going to pull all the abnormal cells. That's going to cause the spleen to get enlarged because it's working so hard, and then it's going to cause the number of red blood cells in circulation to drop, thus resulting in anemia. The other thing that can happen with these blood cells is our capillaries and veins are really not made to transmit blood cells of these abnormal shapes. They're made to really be able to transmit our normal red blood cells. And so when we get abnormal blood cells, such as sickle cell cells, they can actually get wedged in and clot up the normal vasculature. So that can be an issue as well. The other type of hemolytic anemia is thalassemia. And again, this is an abnormal shape. This is more affects people of Italian and Greek descent. And it's an abnormal shape. And so the body pulls these cells and they're left to live on with fewer red blood cells. So this radiographic image demonstrates a patient with thalassemia, and it might be surprising that a blood issue can cause such a prominent appearance on a radiographic image. But what happens with thalassemia is because so many of the red blood cells are being removed due to their abnormal shape that the bone marrow is going to become highly active. and it can become hypertrophic. And some of the things that you can see when this occurs is that this almost hair standing on end appearance in areas where there's increased red bone marrow. So we talked about bone marrow being contained in our flat bones, such as the cranial bones, and so we definitely can see this here, that bone marrow has become overactive, and you see at this hair on end type appearance, which is actually bone. Here's an example of sickle cell anemia. Now, one of the things that can happen with sickle cell anemia, like I mentioned, is that those abnormally shaped cells can actually block the normal progression of blood through the capillary system. And when that happens, you can have some blockage of vessels, and then that can lead to death of cellular tissue. One of the things that they also note is that here on the left, you can see that this is what they call a fishbone appearance of the skeletal spine. And so you'll know this concavity on the superior and inferior portions of the vertebra. And that really comes from, again, being that lack of oxygenation and nutrients provided to the blood, bone structure, limiting the ability of that bone to grow in a normal pattern. Now, polycythemia is the other end of our blood issues. So with anemia, we had, for some reason, a lack of normal oxygen-carrying red blood cells. Polycythemia, on the other hand, is an increased production in our red blood cells, granulocytes or platelets. And granulocytes are a type of white blood cells. And then, of course, platelets, as you remember, are going to be your cells responsible for clotting. So there's a primary and secondary form of polycythemia. The primary form is characterized by hyperplasia of the bone marrow. And if we have overgrowth of our bone marrow, it's going to overproduce our red blood cells. And so that's a pretty simple correlation to make, that too much red blood cell or too much red bone marrow, too many red blood cells, polycythemia. The secondary form, however, is due to a long-term inadequate oxygen supply in patients that have usually some sort of long-standing pulmonary disease, or due to some sort of long-standing heart disease. And because of this, these patients will, because the pulmonary system is not working as well, or the cardiac system is not working as well, the tissues recognize that they're not getting enough oxygen. So they would then try to stimulate the production of red blood cells, thinking that that would fix the problem. So that would be the secondary form. Here's an example of a patient with polycythemia, and they have, because of their excess red blood cell supply, they're going to have these appearances of mediastinal enlargement, because their heart is going to have to work harder to pump all of that blood through their system, and it can cause backing up of blood into the pulmonaries, and it can lead to a very abnormal appearing chest x-ray such as this. That brings us to diseases of the white blood cells. So leukemia would be, this again is an emia, so it is a blood disease of the leuco, which would be the white blood cells. Lymphoma would be lymph cell tumors, and then infectious mononucleosis, which is more of a disease that affects the white blood count. So leukemia is a neoplastic proliferation of white blood cells, and there's two different types, two different major types. Myocytic leukemia, where this is a cancer of the bone marrow, and the cancer of the bone marrow would cause excessive white blood cells to be created. The other type is lymphatic leukemia, and this is a malignancy of the lymph nodes. And remember, our white blood cells were produced by red bone marrow and lymphoid tissue. So lymphatic leukemia would be a problem with the lymph tissue, causing them to overproduce lymphocytes. Either way, we're going to have excessive white blood cells circulated in the bloodstream, which causes a decrease in red blood cells and platelets. So here's an example of leukemia, and this is a patient who's obviously this is a child because you can see their epiphyseal plates are not yet fused, and you can see this irregular pattern in their bone marrow. This would be due to that red bone marrow overproducing white blood cells due to the presence of tumors. That brings us to lymphoma. So this is a tumor of the lymph system. So lymphoma is a neoplasm of lymphoreticular system, and a lymphoreticular system would be the system in the lymph anatomy that is going to produce cells or white blood cells. So in this lymphoma is a neoplasm of those cells within the lymph that produces white blood cells. Now, these can occur in lymph nodes, spleen, or any other lymphoid tissue in parenchymal organs, such as if there's lymphoid tissue spread throughout the gastrointestinal tract, lung, and skin, a lymphoma can occur in any of those areas. Now, the spleen is basically a lymphatic organ. It has a lot of lymph components, and so this is one of the areas commonly affected by lymphoma. There's two major types of lymphoma, Hodgkin's and non-Hodgkin's. Either type of lymphoma can cause a lymph node enlargement, or what we can call lymphadenoma. And it's the lymph node enlargement is the most common radiographic finding of lymphoma. And often we would see these lymph node enlargements in the neck or around the aorta or areas of the mediastinum. And sometimes the lymph nodes can be so large that they would have a mass effect or compress other anatomy. So here you see in this patient that they have lymphoma, and they have an extremely enlarged mediastinum, possibly affecting the thymus gland, really changing the appearance of the mediastinum on this patient. Here you see that some very significant changes in rugae of the stomach, and this would be because of compression by that lymphoid tissue on the general rugae. That brings us to infectious mononucleosis, and this is a self-limited viral disease of the lymphoreticular system. So again, it's going to affect the production of your white blood cells in the lymph system. It's characterized by vague symptoms including a mild fever, fatigue, sore throat, swollen lymph nodes, and often comes with splenomegaly or an enlarged spleen. It's thought to be caused by the Epstein-Barr virus, and it's primarily infects young adults. One of the problems with mononucleosis is that splenomegaly that I mentioned. It also is going to demonstrate some changes that you notice at the hilum of the chest, such as you see in here at this image, demonstrating additional lymph activity in that hilum region. The other problem is with this is lots of times, as I mentioned, it affects younger population. Lots of those younger population are playing sports and other things like that. And with the mononucleosis, they may get an enlarged spleen, and then an enlarged spleen would be at enhanced risk for rupture if they were to be playing large, rough sport, or excuse me, if they're to be continue playing sports such as football or other things. And then a ruptured spleen would obviously be even a more significant issue. So that brings us to our first clicker question. All of the following are hereditary forms of hemolytic anemia except pernicious. Lymphoma affects only the lymph nodes of the chest. This would be false. Now we're going to move on to diseases of our platelets, and remember our platelets are responsible for our blood clotting. So the first one we're going to talk about is hemophilia, and our second is purpura or thrombocytopenia. Now hemophilia is inherited. It's a sex-linked recessive gene, meaning that really only men are going to suffer from this. It's an anomaly where our blood does not coagulate appropriately. It appears only clinically in males because it would be because of its recessiveness. It would not present in females. However, a female could be a carrier. It's characterized by a decrease or absence serum concentration of the anti-hemophilic globulin or factor 8. So the clotting process is a very complex process requiring numerous different factors to make it effective. And with hemophilia, these patients do not contain or contain in lower levels or produce in lower levels this factor 8 that contributes to clotting. So a person who has hemophilia is prone to spontaneous hemorrhage or severe bleeding from even minor cuts or injuries in their lifetime. And so something that would be a very minor injury to somebody else could bleed, and they would have significant difficulty getting the bleeding stopped in somebody with hemophilia. Radiographic changes in hemophilia are usually complications because of recurrent bleeding into the joints, or you could find large areas of, hematomas in a patient where they've had trouble clotting, and so they've had continued bleeding. Here's an example of hemophilia where they've had blood in, that long-term bleeding into the joint. Here it is in the more distal tibia. Purpura, on the other hand, is commonly referred to as thrombocytopenia. And so thrombocyte would be those clotting cells, and penia would mean not enough of them. So this is a deficiency in the number of platelets. It's either due to a decreased production, an increased destruction, or splenic sequestration, which means that the spleen is taking in all of these platelets, and they're basically holding it in the spleen and not letting it out into the rest of the body to do its part there. Purpura results in spontaneous hemorrhages of the skin, mucous membranes of the mouth, or other internal organs. So this is from the decreased number of platelets. Radiographic changes caused by either acute or chronic thrombocytopenic purpura primarily involve the gastrointestinal tract, so it would result in this bleeding of the GI tract. The hemorrhage into the small bowel produces characteristic thickening of mucosal folds in the affected area. These patients would then, if they're bleeding just into the small intestines, they might have black or dark brown stools. If they are bleeding more distally towards the colon rectum area, then they might have red stools. And here's an example of those very prominent swollen markings of the small intestines from thrombocytopenia. So which of these platelet diseases is inherited? It's going to be our hemophilia. Thank you for joining me for this shorter chapter this week. I hope these are some concepts that you can look for and think about as they relate to your patients. So have a wonderful day, and we'll talk to you soon.